Okay, so it's such a pleasure to be here today. Thank you to the organizers for inviting me to speak on COVID-19 testing and therapeutics. So just the objectives of the talk today is to update you on current COVID-19 epidemiology, talk a little bit about emerging variants, understand some of the nuances with COVID-19 testing, and give you a pretty comprehensive overview of COVID-19 therapeutics with a focus on outpatient treatment and a review of risk factors for disease, which I know has been sort of a confusing area. We'll talk a little bit about viral rebounds and then a few slides on long COVID. So let's start with the epi. So this is our latest COVID-19 new hospital admissions and the percent of emergency department visits diagnosed as COVID by week. And so as you can see, the yellow line is the COVID-19 ED visits, and the blue are the hospital admissions. They track pretty closely together. We're following ED visits and hospitalizations right now because our case reporting has fallen off a bit, partly because testing practices across the country changed, and there was a lot of home-based testing. And then with the end of the PHE, a lot of the requirements for reporting to CDC also changed by state. So those data are not quite as useful. But the ED data and the hospital data give us a sense of severe disease, or at least medically attended disease in the country. And we had a very small peak at the end of the summer this year. Cases seem to be trending down. We haven't seen an upsurge yet. We are expecting a winter peak though. And so I just wanted to talk a little bit about the Omicron variant in particular. I'm not sure if you remembered, it was a couple of Thanksgivings ago when the Omicron variant emerged. And it was a pretty significant antigenic shift in this particular virus, the unusually large number of mutations across the SARS-CoV-2 genome. There were about 45 to 52 amino acid changes, deletions, or insertions, 15 within that receptor binding domain, which is how the virus binds to the cell. And it was much more infectious and transmissible than the Delta variant. And although eventually we came to learn that it wasn't quite as severe, just because of the sheer volume of cases, given that increased transmissibility and infectiousness, we did see more burden of disease with Omicron. In laboratory, it had resistance to neutralization by the vaccine and infection-induced antibodies, but our vaccine remains effective against it. And it had some resistance to some therapeutics. So what has happened with Omicron over the last 2 years? Well, it's evolved quite a bit. And currently, the main sublineages in the US are XBB variants. We are watching one called EG.5. I know this graphic is a little bit busy, but that's represented by the orange bar. And then the green bar represents XBB 1.9, 0.2. They both seem to be increasing in proportion across the US. And we're currently following HV.1, which seems to be the fastest growing lineage. It represents about 19% of viruses nationally. So our variant surveillance continues to be very robust and comprehensive. And this is a little bit hard for you to read from where you are, and hopefully you can look at the slides later, but this just describes SARS-CoV-2 viral evolution. You know, the original strain sort of broke off into all of these different sublineages that we're following. And currently the XBB is in the lower part of the far right of this slide. And it just continues and continues to mutate. You can see how many different strains we're seeing of that particular sublineage. The hope is that it will continue to mutate to something that's incredibly mild. Omicron was sort of the first indication of that. But CDC is following these variants very carefully, and we actually do talk with colleagues across the world to see what they're seeing in their areas and to get a sense of severity of disease and how these variants affect immunity induced by the vaccine. So the latest culprit was BA.2.86. This was a new variant that was initially detected in Denmark and Israel. It was first reported in August with specimens collected in July. Contains 35 spike mutations with respect to XBB.1.5, which was the previous predominant variant in the US. So there was concern about this variant because there were so many spike mutations and worry about immune escape. We did designate it as a variant being monitored. We saw the sequence was reported in 15 countries around the world. There were 9 respiratory specimens sequenced in the US from 8 states. 2 states detected it in wastewater. And we continue to follow it and continue to aggregate it. I will say that it really hasn't taken off and it's not a huge concern now. But what CDC does when we identify a variant, we do this type of an assessment where we talk to the states that are reporting seeing it. We get information about clinical severity of disease. We get samples that our own lab processes to understand what mutations the variant has. We have partner agencies that look at vaccine and therapeutic resistance. And so we found that there were multiple individuals who didn't have any links to travel. And so it was essentially homegrown, and the transmissibility relative to other variants still remains unknown. But because it hasn't really taken off, we've really lost concern with it. There was one outbreak in a nursing home in the UK that illustrated that probably in certain settings, it could be a virus that causes outbreaks. Still haven't seen anything in the United States though. And then in terms of the vaccine, in September, the ACIP met to discuss laboratory evidence demonstrating that their vaccine can provide protection against the virus that causes COVID-19, including the BA.2.86 variant. And this is the vaccine that's currently available now that we refer to as the updated vaccine. That vaccine was based on the XBB strain. So it is actually very different from the original COVID-19 vaccine, which was based on Wuhan, because you can see from the slide that I showed you earlier, this virus has evolved considerably. So for those patients that you counsel, particularly older patients, I think it's a really good idea to explain to them that this updated vaccine is giving them protection against the variants that are currently circulating. So just moving on to testing. So this is also another busy slide, but it basically shows you, if you follow antigen and antibody over time, it's showing you when you might likely detect one or the other. And so in the red sort of curve, which is basically representing virus that has been isolated from the respiratory tract, you can see that it actually increases before symptoms even start. So we know that people are infectious about 1 to 2 days before symptoms even start. So when you're doing a history with a patient, you might want to ask them about people that they've seen in the 1 to 2 days prior that could have been exposed if they are testing positive. And then the antigen declines in about a week, maybe 10 days after infection. And then we see the antibody basically being developed in the 14 days after infection. So based on some of these dynamics, you kind of get a sense of which test might be the best to use when you see the patient in terms of detecting infection accurately. And so I will come back to that point, but I just wanted to point out that we have several goals of testing. For the clinical community, really it's diagnostic, testing to determine treatment options. For public health, it's surveillance, so testing to learn, testing to determine prevalence, detect variants, understand the virus. And then there's screening that could be sort of instituted in many settings. Schools are a great example to identify infections in individuals where we could mitigate spread to other close contacts. So for diagnostics, which is what I'm going to focus on, for people who are symptomatic and exposed, and then for screening tests, we use them in specific environments. I mentioned schools, but also nursing homes and healthcare settings. And then before events or travel, and I know this has fallen off a lot, but I think it's still a good idea to consider testing as a public health intervention. And as we go into Thanksgiving, for example, if we know that we're going to see our elderly family members, and we may have had an exposure, all of us being doctors and seeing patients in a season where there is a lot of respiratory virus risk, doesn't hurt to test to make sure you're negative before you see people who are really vulnerable to getting sick. So the timing of testing is really important. If someone is symptomatic, we recommend that they test immediately and they limit their exposure to others. We're also recommending that they start treatment as early as possible if they're eligible. If someone is asymptomatic and they have a known exposure, and that's really important. For asymptomatic people without a known exposure, we don't recommend testing anymore. But with a known exposure, you actually have to wait at least 5 days after the exposure to test. And wearing a high quality mask when around others inside the home or in public for 10 days after exposure really is a good idea. The incubation period of SARS-CoV-2 is about 3 to 5 days. So it may take that long for a person to test positive. And that is why we have the recommendation of testing on day 5. And there is some data, some papers just recently published that showed that the viral load tends to peak at around day 4. So the diagnostic tests are based on nucleic acid or protein. The nucleic acid amplification tests, or NATs, which they're commonly referred to, they're highly sensitive and highly specific. But if you recall the slide that I showed with the curves, PCR is detectable. NATs can detect viral particles for an extended period of time, almost way beyond the period of infectiousness and almost out to 90 days. And so that's why it can be a little bit of a limiting test, because if you're concerned about reinfection, you may not be able to detect a reinfection because a person with an infection will test positive for a very long time. So the rapid antigen tests were developed after the NAT, and they actually turn out to be a very useful tool. They also detect viral protein, but they can be done at the point of care or at home. And so having tests that we can do at home, particularly with the US government distributing them through the mail, has actually been a very convenient and useful public health tool. The problem with them is that they're a little bit less sensitive than the NATs. And so if you have a high index of suspicion that somebody has COVID-19 and there's a negative antigen test, we would either recommend that you reflex to a NAT and confirm that negative, or you wait 48 hours and repeat the antigen. And the FDA recommends that test, if it's negative again, is repeated another time 48 hours later. So certainly if there's a negative antigen test and a high index of suspicion in a person who is eligible for treatment, I would recommend that you just go ahead and get the NAT and make the diagnosis so you can treat that individual. And this is just a schematic that essentially summarizes what I said. I wanted to include it because at the bottom of the slide is a link to the CDC recommendations on how to use antigen testing for SARS-CoV-2 in clinical settings. Again, asymptomatic individuals, you only test them if they have a known exposure. And this is the link to the FDA recommendation that we've already gone through, where if a person is symptomatic, test at least twice, 48 hours apart. A third test might be needed if the patient is concerned they have COVID-19. If they're asymptomatic but believe they have been exposed, test with a rapid antigen test at least 3 times, each 48 hours apart, to be considered truly negative. And then again, consider reflex testing with NAT. And if the NAT is negative, it's pretty certain that it's a negative test. So you can consider other diagnoses like flu, RSV, or strep. So that brings us to the risk factors of severe COVID, because our treatment recommendations are very much aligned with understanding or making an assessment as to how high somebody's risk is for severe disease. And I really feel like this has evolved since therapeutics became available. So here is a graph of our population-based rates of COVID-19 associated hospitalizations. This is from our surveillance system called COVIDnet, where we get data from hospitals across the US. I really want to just draw your attention to the box that is on my right. Those are data from January 1st, September 23rd of this year. And it really just blows up the age-adjusted rates. And you can see it's highest among individuals who are greater than 75 years of age, followed by infants who are less than 6 months, and then adults who are 65 to 74 years of age. And that adults 65 to 74 are about 2 to 3 times less risk than adults greater than 75. So these are actually very promising data. It feels like we're moving out of the pandemic. In the height of the pandemic, we were seeing hospitalizations and deaths in every age group. And this is what we normally see with respiratory pathogens like influenza. It's at the 2 tiers, at the 2 edges of the age spectrum. Usually the very young and the very old are the most vulnerable. So these are data that are a little bit old that we have on our webpage that discusses the risk factors for severe disease. And what's circled in red here are basically the age bands that are at highest risk. And it just really does point out that age is a driver of risk. The odds ratios or the risk ratios that are in purple at the bottom reflect comorbidities. Comorbidities like obesity, diabetes, chronic kidney disease, COPD, coronary artery disease. These are risk ratios for death. And for all of those comorbidities, the risk ratios are quite low compared to age. In the 85 plus age group, the risk ratio for death is about 10. So it just is very clear that age is driving risk. And then at the bottom, we looked at pregnancy and 2 to 5 comorbidities, and both of those actually seem to drive risk more than just one comorbidity. So I wanted to just share with you some more recent publications about risk that were conducted in the Omicron period. And this is one from the Kaiser Permanente group in Northern California. And they basically found that the strongest risk factors for severe outcomes was older age, high body mass index, that hasn't changed, and select comorbidities like diabetes, cardiovascular disease, renal disease, and dementia. And then they use this Charlson Comorbidity Index. I'm not sure if you all are familiar with it, but it's not quite as sophisticated as the Framingham CVD risk scoring, but it does allow you to take into account age, a person's comorbidity, and it estimates their risk of mortality. And I think that might be a useful tool for us moving forward, particularly because the clinical community is used to using risk scores. And this is one that's already been developed and validated, and it's available. And then to point out that vaccination status continues to reduce the risk of severe COVID-19 despite immune evasion by Omicron. So what happens in the lab doesn't necessarily translate in the human body. And then this is just a schematic of those data. And you can see that that bubble at the very top of that graph, that's the 80-plus-year-old age group. And then these are sort of the factors that have an odds ratio less than 5. And I mean, age is just completely a driver. And what's at the top there, I don't know if you can read it, is 3 or more underlying conditions. So the things that we're concerned about are age and multiple conditions. And then this was a nice study that was out of the VA population, so not really generalizable, but they showed similar findings, a strong association, even after vaccination with age. And then immunocompromising conditions, which we know is a concern, and the chronic conditions that have an end organ disease, such as heart failure, dementia, chronic kidney disease. So the same conditions are seemingly coming up. And IDSA has this risk continuum on their webpage that may be helpful in terms of tiering risk, where you can consider some factors like age, vaccination status, medical conditions, immunosuppression, and get a sense of where on this continuum a person may live in terms of higher versus lower risk. It's not very definitive though. And so I will say that the US government has convened a meeting next week for us to review this and talk about this and come up with maybe more definitive recommendations as to who's at high risk of severe disease. It's been a dynamic space throughout the pandemic, but I feel like we're now transitioning to endemic and our data might be more clear moving forward. So in terms of treatment, I'm going to just talk to you about outpatient treatment. The COVID-19 treatment guidelines panel that's led by the NIH recommends two drugs as first-line treatment for COVID-19. One is ritonavir boosted nirmatrelvir, and the other is remdesivir. And then the alternative therapy, which is second line, is molnupiravir. And this is just a schematic as to how those medications work. Nirmatrelvir ritonavir is a protease inhibitor. And so it just blocks the main protease that SARS-CoV-2 uses. And the other two, molnupiravir and remdesivir, actually induce mutagenesis. It's really interesting. Like they essentially force amino acid substitutions. And this is just some details for you about dosing. So nirmatrelvir, ritonavir, you give it for 5 days. You need to give it within 5 days of illness onset. In some individuals, you may need to do some renal dosing. We're not recommending it in persons who have renal insufficiency, a GFR less than 30. Not recommended in severe liver disease either. Remdesivir is an IV infusion over 3 days, and this has made it very challenging to give. It needs to be given within 7 days of onset of illness, and the infusion takes anywhere between 30 minutes to 2 hours. And so it's very 4 hours, sorry, very challenging. And then molnupiravir, that's also a PO medication given for 5 days, within 5 days of illness onset, but its challenge is that we need to use it with caution in people of reproductive age, which is essentially most of the population. And so people should be using birth control if they're using this drug. So the advantages and disadvantages, nirmatrelvir and remdesivir in their clinical efficacy trials actually showed very high efficacy, 88% and 87% respectively, whereas molnupiravir did not. 30% in their efficacy trial. There have been some trials abroad that have shown higher efficacy, but most real-world studies have shown that it's really just a drug that decreases viral load pretty expeditiously, but it doesn't necessarily prevent hospitalizations and deaths in the same way that nirmatrelvir and remdesivir do. And that's why those two are the first-line agents, according to the NIH guidelines panel. The main disadvantage with nirmatrelvir, which is also called Paxlovid, are the drug-drug interactions. And so we really are trying to do what we can to ensure that patients have the tools that physicians have the tools that they need to understand the drug-drug interactions. And this is just from the New England Journal paper that reported the results of the EPIC HR trial that found 88% relative risk reduction in hospitalizations for COVID-19 with use of nirmatrelvir, ritonavir. And then we did look at real-world effectiveness, and we found a differential effect by age. It was much more effective in persons who were greater than 65 years or older. And the EPIC SR trial results that have not been published, that's the standard risk trial, did not show efficacy. And so we really shouldn't be giving this drug in patients who are at standard risk. To manage the drug interactions, this Liverpool drug interaction database, I think, is so great. If you go to that website, what you can do is in one column, you can plug in the drug that you want to give, the COVID-19 medication that you want to give. In the other column, you plug in what patients are on. Statins are one of the most common medications that has an interaction with Paxlovid. But it will tell you exactly what you need to do, whether you need to stop it for 5 days, dose adjust it, or whether it's just fine. And there are some statins that are just fine, like Paxstatin. And this is just a schematic of what it looks like. Really useful tool. I love this. And if you are treating patients and you need help managing the drug interactions, I really think that this is a really nice way to do it. The other nice way to do it is to have a pharmacist go through the whole list of medications like we do in our HIV clinics to make sure there aren't any concerning drug interactions. One thing that happened with Paxlovid last year is that there were reports of recurrent illness a few days after taking the medication. And the manufacturer had noted in a clinical trial that a small number of participants did test positive after testing negative. And they observed this in persons who were both randomized to Paxlovid and to placebo. And there was no increased occurrence of hospitalization or death with rebound. And there was no evidence that there was rebound in detectable viral RNA due to resistance to Paxlovid. And we do continue to follow this. And this was a paper that was published subsequently using EPIC HR data that shows you in both the treatment group as well as the placebo group, there was a very clear decline in viral load. And then in the bottom two graphs, you see both in the treatment group and the placebo group, there was a lot of fluctuation in viral load. So we did see, quote unquote, rebound of virus in both groups. And then there have been a number of observational studies on this topic. And we found that most people who experience rebound have mild illness, that symptoms resolve in a few days. They don't require retreatment. They don't necessarily get so sick that they need medical care. It doesn't seem that rebound reflects reinfection with the virus or resistance to treatment, but we really are following the resistance aspect. It's relatively infrequent. Less than 10% of people report rebound. A few cases have had culturable virus, which is why CDC's recommendation to re-isolate when rebound occurs is still in place. And we've seen it in patients treated with molnupiravir as well as Paxlovid, and there have been a number of reports in untreated patients, including the active trial that looked at their placebo arm and found rebound does seem to occur in patients naturally. And so in summary, it's likely a natural disease process and happens regardless of vaccination or treatment status and corresponds with a robust immune response. Persons on treatment may be at higher risk for rebound given the drug pressure that suppresses viral RNA. And it's likely that's what we're seeing in the early course of infection, that when we remove that drug in some individuals, the virus reactivates because they haven't necessarily cleared it yet. And we've seen this with other viruses such as HIV. Partly this could be due to ascertainment bias because persons on treatment are closely followed. And then it's also possible that viral rebound occurs in persons on treatment because they're also at high risk for severe disease and may have host factors that contribute to their vulnerability to rebound or their vulnerability to not necessarily clear the virus. And so we need more data on the risk factors for rebound, but we do have some studies underway looking at longer courses of treatment and also a repeat treatment. And we would think that those longer courses of treatment would be most appropriate for people who are immunosuppressed and most likely to rebound. It does seem it has something to do with host factors and your inability to mount an immune response. So this is the study that looked at early remdesivir. And these are the data that show that remdesivir had an 88% relative risk reduction in hospitalizations or death. It's pretty significant. Remdesivir is also a drug that you use in inpatient settings, and it's probably more appropriate for inpatient settings, but there is an oral formulation of remdesivir. China actually, I think, has already approved their version of it. I think Gilead is making one for the US, and FDA is eagerly awaiting their application because oral remdesivir actually could change the whole treatment space. I think I'm going to skip over this slide. And then lastly, I just wanted to say a few things about treatment across the COVID-19 spectrum. We know that some people have COVID-19, acute COVID. It can be very mild, it can be severe, but they have it and then they completely recover from it. And then other people have an extended course of very severe disease or they get sick again. And it really is due to an intense immune reaction, it seems, to the disease. And so, you know, severe disease can involve lung involvement and hypoxemia. Critical disease usually involves ECMO or some sort of ventilation. And often we give immune modulators in this setting and corticosteroids in this setting. And so I think it's really important to keep in mind that there's an immune process here that is contributing to the severity of disease. A lot of biologics are now being used to treat severe COVID, and there's a lot of studies underway looking at how we can use these biologics, such as JAK inhibitors, IL-6 inhibitors, TNF-alpha inhibitors, for example. So our rheumatologists are very familiar with these drugs, and some of them come from the rheumatology world that are now being used for COVID-19. And this is just a summary of what all the guidelines say. So, you know, who to treat if somebody is hospitalized. Remdesivir is consistent for people who do not require oxygen. For people who do, remdesivir plus dexamethasone is consistent across the board. IDSA and WHO recommend either baricitinib or tocilizumab. And then for people who are really severe, who require mechanical ventilation or ECMO, you can also use some biologics. They're actually in the asterisk at the bottom of the slide. That's sort of a critical care area. I'm not sure we have a lot of critical care folks in the room, so I decided to just focus on outpatient treatment. So just moving to post-COVID conditions, this has been a very interesting field. The US government is really focused on understanding long COVID and has put a lot of resources to it. You may not know that we actually also published a research agenda for post-COVID conditions. About 1 in 5 adults age 18 and older have a health condition that might be related to a previous COVID-19 illness, and it seems to affect a number of the organ systems: neurologic, kidney, musculoskeletal, cardiovascular, respiratory, hematologic disorders, are only to name a few. And some of the symptoms that we see, like there's general symptoms of fatigue, like chronic fatigue syndrome. symptoms that get worse after physical or mental effort, post-exertional, fever. The cardiovascular and respiratory symptoms can be very severe. We do see sort of long-term cardiac and lung manifestations of long COVID, digestive symptoms like diarrhea. Neurologic is really concerning, and there's a whole field looking at this. Most people find it very hard to think. The brain fog that you hear, it seems really real. And some people I know have actually stopped working and retired because the brain fog was so bad, they didn't think that they could maintain their employment. So that's a significant concern. And then, of course, the musculoskeletal problems. And so why is this happening? Well, there have been a number of proposed mechanisms. Immune dysregulation, which I think is really interesting because it does seem like perhaps with a new virus, our own immune systems are sort of overactive, and that is actually affecting how the body can control the actual virus. We've learned recently that it forms viral reservoirs, and those viral reservoirs can be latent or then reactivate. And it seems like people with long COVID do have reservoirs of SARS-CoV-2. Could be something to do with the microbiota in the GI tract, autoimmunity or imprinting. The blood clotting and endothelial abnormalities are very interesting. We were even thinking that there were like leaky vessels that could be contributing to this. And then dysfunctional neurologic signaling that we don't truly understand. But this was a really nice paper that was published in Nature that kind of went through the number of hypotheses that can help you understand some of the manifestations. And I wanted to share this really nice systematic review of risk factors associated with post-COVID conditions. They found that there's increased risk of developing long COVID among females, people who were older, people who had a high BMI or obesity, and smokers, but that the highest risk was associated with the presence of multiple comorbidities and previous hospitalization or severe disease. So this is another reason for us to think about how we can prevent severe disease, and it makes another case for treatment. And then there's a list of the comorbidities, and it includes the same usual suspects, right? Asthma, chronic kidney disease, chronic obstructive pulmonary disease, diabetes, immunosuppression, ischemic heart disease. These seem to be coming up in various studies over and over again. And it's true that somebody who's morbidly obese is likely a diabetic. So there's some overlap. Those people likely have some cardiovascular disease. And then this review very nicely showed that vaccination provides protection against developing long COVID. So it's another reason to encourage your patients to get vaccinated. It's also associated with SARS-CoV-2 reinfection. This was a study in US veterans, more than 5 million US veterans who had SARS-CoV-2 reinfection, which more than 2 reinfections was, the N was 40,000 people, and they found that death was 2 times higher, hospitalization 3 times higher, and the sequelae included pulmonary, cardiovascular, hematologic, GI, mental health, musculoskeletal, neurologic manifestations. And this is another nice systematic review that showed that vaccination does prevent long COVID. Just including that as a reference for you. And here's the hazard ratio from that study, showing that from another study showing that Paxlovid might reduce the risk of long COVID. There's not enough data for us to recommend the use of Paxlovid to prevent long COVID, but it's definitely an evolving field. And it's certainly a reason to treat your patients early to prevent severe disease and then potentially prevent long COVID down the line. And I just have some resources here for you from our web, and that's all. I'll take questions.
Thank you, Dr. Patel, for your presentation. We'll open it up to the audience for any questions. I will start with one. There's been some talk about metformin and PCC or long COVID. I didn't know there have been any developments or other research done by CDC on that, but I was just curious, kind of any thoughts about metformin and its role, if any, for long COVID.
Sure. Yeah, there were two studies that looked at metformin, and they both had contradictory results. And so the NIH guidelines panel reviewed those data and decided there was insufficient evidence regarding metformin, particularly in terms of treating long COVID. But I'm sure there will be more studies coming. The other thing to keep in mind is that the people who use metformin, diabetics, seem to be at high risk of developing long COVID. And so there's just an association there as well.
Yes, have you seen any decrease in the sensitivity of the testing with the newer variants, or concern for that?
Yeah, that's a great question. So right now, all the tests are able to detect the currently circulating variants. The FDA does have a program where they evaluate the performance of the tests based on the variants that are circulating. And so that is continually being done. And they actually do have a web page where, they post those results. And if there is something concerning, we have communication with at least the laboratories across the country. And so this is an ongoing sort of surveillance that's happening. I can hear you. Oh, I love it.
Anyway, question. I know, we've seen a lot of stuff about baricitinib, the JAKs, and everything else. Has there been anything looked at with the JAKs in terms of the long COVID patient?
No, not yet.
Oh,
not yet. But maybe you have some insight that you would like to share in terms of mechanisms and why certain medications, certain biologics and immune modulators seem to be working.
Well, I think the IL-6 related ones, which are JAKs and baricitinib and so forth, as well as the tofacitinib or tocilizumab. Tofacitinib, well, there's another one too. The thing is, I think, I sort of have felt that maybe a lot of what's going on in COVID is a hyperreactivity, and your body is sort of revved up and everything and going too strong, and that's trying to calm down, doing too much. That's been my feeling about a lot of the cases, because I just think the fact that the IL-6 base drugs, which I include JAK because they do trigger IL-6 inside, but I think, that's my gut feeling. But the question is, I think we need to be looking, is there an immunologic basis for the long COVID stuff? I have so far not had any patients on JAKs that have had long COVID. I can just say that. But I mean, because there have been patients referred to me with long COVID that also have a weekly positive ANA, which means I am now gainfully employed for the next 100 years. The biggest thing is, though, to be honest with you, I think the fact that these patients have the long COVID patients have a pretty significant percentage of patients having a low positive ANA suggests to me there probably is some ongoing low-grade inflammatory process. And that's where I wonder whether baricitinib or one of those other medicines might be worth looking into for the patients with long COVID.
Yeah, I think there's a lot of research on using these immune modulators in treating acute COVID. But for long COVID, those studies haven't necessarily taken off yet, because I think that the feeling is what you use to treat acute COVID and prevent severe disease will likely prevent long COVID, and you may not need to actually treat long COVID. And maybe it's too late once somebody develops long COVID. I don't know. But
a lot of the patients who have long COVID seem to have very similar symptoms.
Yep.
which I think maybe, that, given the final out is very complex one. Yeah, I think it's a lot more dysregulation of the neurotransmitters for the brain. And so maybe this is the same realm, dysregulation on the neuronic pathway.
Yeah, maybe. We do also see this chronic hyperinflammation with HIV patients, which put them at higher risk for certain chronic comorbidities. So even though we've given them these medications that save them from dying from HIV, because of the chronic inflammation, they still die from these chronic conditions. And so there is something about the virus setting up a reservoir and then causing some immune processes that contributes to the signs and the symptoms. And I will say that we at CDC, we didn't really think we were on anyone's radar, and then COVID happened, and now the field of public health is front and foremost. And so we're gainfully employed for as long as we want to be, but I am happy to retire after this pandemic. And I know all of you have been sort of through it as well. So I do want to thank you for caring for these patients. It really is appreciated, and we recognize how much the healthcare community went through during the pandemic.
I have one quick question. A real quick question about antibody testing. A lot of times with my patients, I've seen a decrease when we test for antibodies, even from 5 to 15% per month. But after they've gotten COVID, I've seen as high as 25,000. I'm understanding that you need something like 400 to 600 to have adequate immunity. Do you know anything about that as far as guiding my patients for these new vaccines?
So we're actually recommending against using serology to understand whether somebody has immunity, because we haven't correlated the levels of antibody titers in these various tests with true immunity, which we think of as neutralization antibodies. And so those neutralization antibody tests are really only done sort of in a research setting. We do them at CDC, and some research institutes do them, but they're not commercially available. So currently, the NIH, CDC, we're not recommending the use of serology to direct clinical decision-making.
Questions? Oh, one back there.
So prophylactic treatment, so post-exposure prophylaxis is it's not an indication of Paxlovid or any of the medications right now. We did have pre-exposure prophylaxis with Evusheld that we were giving to immunosuppressed patients. Unfortunately, we had to pull Evusheld earlier this year because it was no longer effective against the currently circulating variants. And AstraZeneca that made Evusheld did make Evusheld 2.0, but unfortunately the virus has mutated so much this year that monoclonal antibody is also resistant. And so it may be a while before we have pre-exposure prophylaxis again.